my question is, do you want just to take over the National Tumor Board and have all of the retinoblastoma community invited to tumor board? Would that fit the need so that the education piece is aimed at everybody? Or are we asking them to present differently to both groups? And how do we coordinate it so that we're not burdening people who are showing their research and taking time out of their work to do that?
Right. Yeah, we've had a great success with the timing that we've had for our researchers and health professionals who are attending. So the timing was good, but I do have comments collected from our past presenters saying they don't see a lot of patient partners attending the cup of tea. So sometimes we seem to get more of one and then less of the other, and I don't want to lose either group. Would you say if there was a change to the timing, would our non-patient partners still attend, or would we lose them if we move or do something different?
I don't know that it's only the timing. Like, we worked back and forth to try and get everybody on to do patient related material. And so when we invite somebody to present to us, we've invited Jessie Berry kind of on an ongoing basis, but we just had one that was on genetics, for example. And we had Jessie, and we had somebody from Israel, and we had people from Toronto, and they all attended at what would be an evening session in Toronto, an end of workday session in Vancouver and Los Angeles, right? So I don't know how much traction or how much ability the people we're asking for have to intersect multiple times, once with the National Tumor Board and once with the CRRAB related cup of tea. And my question is, should we be combining them? Could we get clinicians at other times? Everybody makes time for what they can, just depends on the outcome, I guess.
You've brought this up before, Catherine. As someone who's attended both Cup of Tea and the National Tumor Board, I mean, the majority of National Tumor Board is discussing treatment. I don't think that's the right thing for the patient community. And as Eva has said, then the weeks where we have Cup of Tea, we do have even Jessie Berry attends. She doesn't have to, but I think she likes coming to the Cup of Tea. And then those people who are at Cup of Tea come to National Tumor Board. I've also noticed that those who don't want to come to Cup of Tea, they're still at National Tumor Board. The extra bit, like the other week where you invited Dee Dee and Jessie to present their presentations from the clinical conference, it's not a bad idea to have patients hear those as well, but I do think the format would be very confusing to most. Like, nothing is simplified. I think even medical professionals who don't understand genetics would find it too complex. So I think it would be a lot to ask the patients to attend those. I think we've studied the challenge, or like the perceived challenge, that maybe by having Cup of Tea right before the National Tumor Board, that we're somehow deterring people from coming to National Tumor Board. But I think those who don't want to come to Cup of Tea don't come, and I think it's working. Have you noticed any other challenges? Because from my perspective, I think it's working okay like this.
It's not so much the cup of tea.
Okay.
Right? It's how do we ask Tim Corson to come to both, or how do we ask Jessie Berry? No, I'm just really respectful of the fact that all of us are working at least 6.5 days a week now, because you can do it virtually, and people ask you to come in the evening when you're in Toronto, or basically at bedtime in Halifax. And so I just want to rationalize it, and if we're leaving them separate, to make sure that we position it with the people we're inviting, so that they understand what the different audience is. I'm not saying there's anything wrong with doing Cup of Tea then. We've got 4 of them out of 10 tumor boards a year. And so, if that's working, that's great. And I think the tumor board folks enjoy hearing the perspective, it makes us all more sensitive to what the patient and family population want and need and understand. And it also makes us really educated about how sophisticated some of them are, right? You didn't talk about collecting the expertise of your volunteers, but you've got volunteers with all kinds of expertise in all of these areas. So it's only that business of trying to make it clear and then rationalizing, either so we invite them to do both, cup of tea and present to the docs afterwards, or that we have some kind of communication about when we're doing it or what works for them, so we're clear and they don't look at the Canadian group overall to say, well, what am I doing? You know, what does it translate to? That's all, because we're small enough that we're the Canadians.
Yeah.
Or we're sick kids retinoblastoma program, to be honest.
Okay, great. Thank you. Sorry, I'm just cognizant of time, and even has got this lovely whiteboard to populate.
I wrote some notes down from that, Dr. Payton, and we can continue the conversation offline. If we can try to get through as many of these as we can, so we have some good support in developing the cups of tea in the future. So let's start with the second cancer screening risks. The question is, what do you want to know about this? What do you want to know more about second cancer screening? If there's specific topics, if there's something specific that we can delve deeper into, what this will do is provide a list for our patient partners to choose from. So what I do when I'm doing cup of tea, I'll ask the patient partner to tell me what they're most interested in learning about. So this is as much a learning experience for them, and not just to read the article and understand it, but also to answer a question that they've had about their retinoblastoma journey.
I don't seem to have access to I'm not sure what's going on with my bureau. I don't have access to exactly what you have up here, but I can provide you some ideas.
Go in the chat. She's posted a link to a new board.
Oh, okay. Maybe can I just say it
absolutely.
And then somebody type in for me?
Yeah.
On a green, I would be, I guess, a green post-it. And so this is going to reflect my current ignorance, because I really have been out of this field for so many years. So what I am most concerned about at this stage in my life is how to access what is ideal second cancer screening. So I'm in my early 40s, and like, I don't know if there are papers that are out there that outline this exactly, but this is a keen interest, and one that I have found that any GPs I speak to have no clue about. So that's one point. I'll keep it at that for now.
I would agree with that, because my experience with my daughter is going back 40 years now. But at that time, there was no kind of a set of guidelines what to watch for. And so all I could tell her all her life, I felt like I was drumming it into her, is if you ever notice anything unusual about your health, go to a doctor right away. And
so what is the ideal screening is maybe the better question even then. Yeah.
Can I suggest a partner and also a screening thing? We've got a survivorship program here called LEAF, and somebody who does the retinoblastoma ones. I don't always agree with what they do, but they've got a template and research references behind it, and it's well articulated. And I'm very grateful to have it, because most of the GPs don't know. So the partner would be Karen Goddard, Dr. Karen Goddard.
Amazing. Thank you, Catherine.
And the documents there, and they could talk to what the research was behind it that put it together in the first place. And then we have had the conversation before. I think Bruce Crooks is the other person out in Nova Scotia who's got an interest in this. So I don't know if they've currently got a program, but it would be good to hear, and then it might give us a chance to advocate right across the country so that everybody's on the same program.
Totally. And sorry.
Well, not just within Canada, because my daughter's experience, she lived and worked in the United States for the last 12 years of her life. And she was fortunate to be working where there was a medical school. But is there some kind of a list of people in North America even that would be specialists that she could consult with? She could have.
Exactly. Exactly. And I think Bruce Crooks, like at the last symposium, he spoke to this a little bit, but he had like 5 minutes and he had so much to say. And so hearing from him as a speaker would be amazing. And that's absolutely not to dismiss what you've said, Catherine. I think that, I don't know if we can have both of them, like just highly valuable.
Possibly one for cup of tea, maybe for symposium discussion or something, right?
Yeah.
It's a tough one because I think we don't have a lot of the questions answered that we want answered. And even the progress made in molecular cancer surveillance for people with RB, like for people with heritable cancers, it doesn't include RB. And so I know Brenda, Stephanie, our team at SickKids has been trying to get funding so we could join this CHARM consortium. And that was the focus of the cup of tea. We sort of invited someone from the CHARM consortium to tell us how their screening program is happening. Again, it's not standard of care. It's under research to see, can screening the blood detect cancers early? And we'd like to be able to further develop and test this to see, can it detect the complement of cancers that RB survivors should be, aware of as potentially being, them being at risk for? Can this blood test, reliably detect that? I think that's the research that needs to be done. We don't have the research yet.
Oh, because I thought last year at the research symposium in January, one of the doctors reported on studies, and I thought they were into clinical trials or about to start clinical trials for blood tests so that people could go to a local lab instead of having to come to Toronto.
Exactly. And that does not include retinoblastoma survivors, the funding. And that's exactly my point about being very clear about when we present research, because sometimes we're not being clear to say what's being done on retinoblastoma families, what's not. CHARM consortium could very well be for RB patients. Blood from one person was collected and banked at CHARM, but they don't have the funding to study it, which is like such a challenge. We applied for a grant to do this, and the granting agency says, well, CHARM consortium has so much money, why do you need our money? Because they're not testing blood from RB patients. It was so frustrating.
Well, what about the money in Sarah's fund?
It has not yet been applied.
I know that, but I don't know how much is there or anything, but I mean,
we can ask Brenda, because that's certainly an important bit. It's a lot of money though for these trials. I think if it was enough, we would have started.
Yeah.
We should start, and even as a pilot study. But it actually has a lot of upfront costs. Maybe we can talk.
Sorry, as a parent, like, can you give, what does this kind of stuff cost?
Right now it's under research. Yeah. So like this trial, this CHARM consortium, in order to enroll the high number of patients you'd need to be able to scientifically say this works, we're talking about $1 million trials. So they have a lot of money from multiple sources. If you go on the CHARM consortium website, you'll see that it's been multi-year, starting with a little bit of seed money from like hundreds of thousands from Terry Fox Foundation, from, I'm sure there's some foundation funds from the University Health Network hospitals, the Canadian Cancer Society, like all different grant funders funding little bits that build up to this current trial, where if you have any one of, I think, 3 or 4 heritable cancer syndromes that affect adults, that's what a lot more funding goes to adult cancers. So people with, I think, breast cancer syndrome or Lynch syndrome, which affects, it's like retinoblastoma, which can give you breast cancer and a lot of other cancers, throughout your lifetime. These people are eligible and they can enroll, and the research study pays for their screening, but they're part of a research study. We don't actually know that it will detect the cancer, which cancers it will detect better than others. There's a lot of research we need to know about how you were treated and what your genetic makeup is like, and how the treatment might have affected your genetic makeup to make you more or less prone to any different type of cancers. I think we need to really have, the challenge with RB is we have such small numbers that it's hard to collect the data systematically worldwide to know at which point is someone at risk for melanoma versus osteosarcoma, and how does your history affect that risk? We know it broadly, but not too specifically.
So Helen, that's the difference between the sort of research end versus a personalized current roadmap.
Exactly.
And I
Yeah.
think a personalized current roadmap is still available. It depends on which treatments you've had.
Right.
And when and where they're applied. And it's an evolution because of the decreased amount of radiation
Exactly.
and the other things. So I still think the business of having some kind of program that looks at retinoblastoma is kind of where we should start. And that's where this LEAF program came in. I have multiple patients. I don't some of whom are members of this group, but aren't on the call right now. So I don't want to out anybody to stick them in a patient partner position, but we've got a few of them. I don't see why we couldn't get them to be part of that conversation, you know, because I think the business of saying we know there are risks, somebody is monitoring regularly. So they end up having imaging and other things that reviewed at particular time points. And although it feels a bit cookie cutter to me, it is personalized to which treatments they had. So, and it's got some risk justification behind it. It's not all the epigenetics and not all the, you know, new take a blood test, don't ever have anything else, but it's better than not having anything out there. And maybe it will persuade people to at least collect that data. Even the Global Retinoblastoma Consortium doesn't have anything that's capturing that data right now.
Right.
I think we can have so much conversation about this topic, but if we can try to fill in a couple of more sections, I just want to make sure, Sue Marine, if you had any ideas also you would like to add before I move to the next.
The audio now unmuted. No, not really. I just agree with what was said, because like my personal experience is that I found out after my second cancer that the one of the reasons that I had developed it is because I was born with retinoblastoma, and then my third cancer, I'm just assuming that was also an effect of RB. So yeah, having that information that would be very helpful.
Thank you.
I think the idea of like having people who run survivorship clinics to tell us what's being done currently and what evidence that's based on is probably a great start, like Catherine's been saying and Simreen has pointed out the importance of.
Okay. So let's see about 3D printing. What do we want to know more about 3D printing?
I don't know anything about it. So what I guess is what is currently being done?
I was wondering when the doctor was talking about using it as a printing out an eye so to train doctors to recognize retinoblastoma. I was wondering whether it would also be a method of creating prosthesis faster than going through the regular process.
Maybe not necessarily faster, but in more volume. That's why Moorfields has used it.
Yeah.
So my question here is this because this is, I'm assuming, fairly new technology, or is there actual research to share on this? Like, I know you've got the project, but this is, I guess, comes down to where we were talking before. Do we always have to share like published journal papers, or is this an opportunity to share up and coming or current research that's is being worked on but not completed?
I think you're right, Lindsay. Both of these projects are might have some data that has been published, but overall it's a longer term project. So I think for Ashwin, he probably has some data that's about to be published. Mandeep Sagu, they've, as Catherine mentioned, they're actually using it in clinical care, but maybe they're in the middle of their trial to understand outcomes like how patients like the look and the feel and the function of these eyes and how they compare to the traditional custom fit eyes. So I think it is more of a research in progress theme.
But I think that's okay sometimes.
Yeah.
Like, I guess I don't know what the, what CRRAB, the objective is. Does it always have to be published research? Like, it's ongoing research, right?
Yeah, I think it can be ongoing. We just will have to be cognizant of how we structure our patient education. Because as we saw, like Kathy nicely pointed out, that last year we had Trevor Pugh as part of the CHARM consortium talking about his finished research, but we hadn't done a good job of explaining that hadn't been done on RB families, right? So, yeah.
So
Okay.
it sounds like here we have the non-patient partners to approach. Is there any patients who are currently
UK? You'd need to find a UK, and Mandeep would be the one to provide that or not?
Yeah.
But yes,
yeah,
it's
like I would
published stuff.
assume some of the doctors have, I don't know, I don't understand how this works, but like, you have contacts or patients that you, I guess, have relationships with, that are you allowed to ask them if they would participate in something like this?
I think so. I think a clinician can do the reaching out, like if Mandeep and Ashwin had patient partners. Yeah.
Well, it's a good idea for them to recommend someone, and then it's someone they have a relationship with and would make that work easier.
Yeah, like as a parent, I don't know what all the ethical rules are, but I personally wouldn't have been offended if someone reached out to me to ask me to help with something, right? So.
In fact, I would say as a patient that I would welcome that.
Yeah, you want to partner, and that's where those comments Ivana was making at the start, where helping to further research for future families, patients, clinicians, right?
Okay, let's see what we can get for impact of RB on daily living. And there's already a comment here. What aspects of daily living do RB patients have the most challenges with? And I would add to that, what supports are already available and how can people access them? People might not know.
I'm a little concerned that this is a really diffuse topic, and it will be so dependent on, like, it's really broad. The impact will vary from a unilateral with an enucleation and problems with the enucleation to a bilateral who's got, some hearing impact from a drug they were given or something else. Is there some way of coning down on the topic, or am I just misunderstanding it?
I think you're right. Like, it all comes to personal experience here.
It's Sabrine. One of the points about this too is like it's just dealing with the vision loss and the impacts it has on daily living activities in general. So not necessarily the specific nature of the type of retinoblastoma, but just the fact of dealing with vision loss in general. Like, for example, at Vision Loss Rehab Canada, where I work as an independent living specialist, when we have clients come in, we look at the whole picture, and we do individualized assessments. So for example, a person that has vision in one eye, we would teach the same skills, the daily living skills, but then gear the training towards what their level of vision is or what their challenges are. and we make up individualized plans according to that. And same thing if they have hearing loss in addition to the vision loss. So it's very customized programming. And the daily living skills, they involved not only the activities of daily living, but ranging from home management skills and communication skills using computer with access technology. There's a part of it is also some supportive counseling. So it's all encompassing, but at the same time, it's individualized as well.
So I guess maybe the unifying part is more the psychosocial impact on the individual or family from having to repeatedly cope or repeatedly remind of limitations. That business of you're never quite free of it. How does that impact you? Because I don't know how to tie together people who've got big vision impact, which sometimes happened, with people who've had lots of treatment and have kept both eyes and function well visually. It's impact of RB on daily living. Whereas people with a disability often find just having to kind of be their own advocate all the time, be the advocate with the teacher or the school system or the transit system, whatever it is burdensome and the thing that they struggle with the most.
I think as a patient, and I mean, I come from the group who has a disability as a result, so recognizing the position that I come from, but I think the impact on vision is really important. Like the kind of stuff that Simreen talked about, I think is not talked about enough in this community. So I hear what you're saying, Catherine, but I guess I worry a little bit about focusing on an underlying psychosocial impact and not also addressing the services or approaches aspect. Yeah, just a perspective on that front.
That's really helpful, Ella. So I guess the next question is educating across the retinoblastoma community, because there are folks all the way from people in situations like yourself or people who've had both eyes enucleated and yet cope and do things well, to people who've got one completely normally functioning eye or two basically normally functioning eyes. And so it's broad. Those of us who work in the field recognize the challenges, but we're presenting it as cup of tea. So how would you like to approach that? That's kind of my question.
And it's such a good question. It's such an enormous thing, and I realize this is one cup of tea, and so I don't know how to answer your question or address it.
But could we pick? But could we narrow in on this topic, like Ivana was saying before, like to vision loss, the impact of vision loss in daily living, like as opposed like because these are broad and like on, I think, like even on the 3D it was eyes for training versus eyes for humans, right? So is this where we could narrow in on like one specific impact or something RB has created?
Vision loss isn't one impact, is what I'm saying. The degree of vision loss is completely variable. Ella, I know you've got lots of work to do.
I'm sorry, I just got noticed that a lot of the others have finished and are waiting. Even I don't know if they've been sending you any warnings of time. But the other breakout groups seem to have finished.
Are they waiting for us?
Yeah, I thought they were communicating with you, but I guess not.
Sorry, I was listening to people's conversations and enjoying that we were having this good discussion. So we've captured enough information till September. So we just need December, but